Good afternoon, everyone. Good evening for some of you, good night for others, and even good morning to those in Australia that are joining us today for this webinar on Whiplash. My name is Jan Dommerholt. I'm the president of Myopane Seminars, and it is truly a pleasure to welcome you all here for today's webinar. We have close to 300 people signed up for this webinar tonight, so we're very excited. And as has become the history now with these webinar series, people have signed up from as far as Australia, Pakistan, Lebanon, Qatar, Kuwait, Dubai, Latvia, the Netherlands, Belgium, Switzerland, name it, Mexico, I believe, Peru, Ecuador, United States, Canada, etc. So, what a great opportunity to share information with each other as mostly physical therapists and a few other professions, of course, in these tricky COVID times. Here in the United States, we are dealing with this in a somewhat poor manner, in my opinion, but that's the way it is. With lots of openings of businesses and all that, and the COVID business, of course, does not really care about what we do, but it's still going on. So in other countries, you're doing a little bit better than we are doing here. Hopefully, we'll catch up here in the United States. But I think it's a wonderful opportunity to be able to share this and to kind of connect with physical therapists and former students and hopefully future students all over the world with this educational effort. Whiplash, first used in 1928 by Crow in the United States to describe the motions of the head and neck during a motor vehicle crash. A very generic description, just to get a sense of what it goes. Now, in other countries, there's similar terms developed. Today, we talk more about whiplash-associated disorders, and whiplash is kind of like the crash itself. We refer to now as whiplash, but the symptoms that people get after that are often referred to as whiplash-associated disorders. And you also see cervical acceleration, deceleration injuries. These are all the same. In addition to my physical therapy degrees, I also have a master's in biomechanical trauma, which gave me a lot of knowledge, a lot of information about car accidents, particularly whiplash, of course. And I'm also certified by the Spine Research Institute of San Diego by Dr. Arthur Croft, who used to have this program. This program is no longer in existence, I believe, but it was a lovely program to learn a lot about the legal aspects of whiplash, how to testify in court, but also about the research that we currently have available. So before we talk about whiplash, I want to spend a few minutes on talking about the issues with what happens, how bad is it, what happens in car accidents in general. Now, the World Health Organization publishes a road safety report every so many years with all that information. So I've summarized a little bit for you here. And believe it or not, car crashes take 3,700 lives a day worldwide, or 1.35 million lives a year. That's quite a lot. To compare it to COVID, as of yesterday, COVID has claimed 469,000 people's lives, which of course is a lot, considering it's a fairly short period of time. In the United States, there's actually a decrease in the number of car crashes and fatalities in car crashes over the years. So in 1975, there were still 44,000 people who died from car crashes. And in the last numbers available, 2017, 2018, is just coming out, it went down to 36,000. If you look at it, the fatality rate per 100 miles with vehicle miles driven, like how many miles people actually drive, that number has actually gone down even more because people drive more, so relatively per number of miles driven, that number has gone down a lot. So in 2018, it was 36,560 people got killed in car accidents. So far, COVID in the United States has claimed 120,000 people's lives. So in that sense, the COVID pandemic is very devastating as far as the number of people who have lost their life. And certainly if you consider how many more people likely will lose their life, it is actually even quite shocking. But let's go on. A lot of these deaths are related to alcohol. As you can see here in 2018, the numbers here, almost a third of all fatalities were linked to alcohol. So 10,000 people died from alcohol-related car crashes. About the same in 2017, very small changes. If you look a little bit further, of all these people who died, 26% of the people who died were involved in crashes where at least one of the drivers was speeding. Yeah, makes you think a little bit, doesn't it? Studies in China have shown that even a 1% increase in the mean speed was associated with an immediate increase in total crashes. This is in an urban region in Shanghai, I believe. So even a 1% increase in speed, which is nothing because you hit that gas pedal and before you know you're much faster, immediately had an increase in total crashes. Back to the States, if you look at the number of passengers who were killed and who do not wear a seatbelt, in 2017, that was 47% of passengers who were killed and unrestrained, 47%. Now that number is slowly going down because seatbelt use is actually improving a little bit. If you look at it by age, you see that there's a remarkable difference, certainly in the teenage years and early 20s, early 30s. A lot of people, relatively more people died because they did not wear seatbelts. The younger kids are kids that sitting in the car, clearly they were not driving themselves, but it's quite shocking how many children drive in cars without the proper restraint systems in place, either car seats or seat belts if they're old enough, or a combination of the two. If you look at the survival rate and restraint use, the people who survived, clearly the seatbelt use was significantly higher. Seatbelts actually save lives. They're worth it. Airbags don't really save lives as much. They just prevent you from hitting the steering wheel. But the seatbelt is really the critical thing. So if nothing else, if you learn from this lecture, do not drive without your seatbelt on, I'm happy because lives will be saved. So did you know that car accidents are the leading killer in children and young people between 5 and 29 years of age? Many of those are pedestrians. They got hit by cars, hit by buses, hit by others. And that's very unfortunately. In the United States, more specifically in 2017, that data was particularly for children of 3, 11, and 12 years old and 17 to 21. That's just what the studies show. It doesn't really matter what if you're 3 or 4 years old if you get hit by a car, of course. But it's quite shocking that is the leading killer of children in those young ages. Overall, car crashes are the 8th leading cause of death in the world. So quite serious. And the sad part is that all car crashes are preventable with the proper restraints in place. I'll get back to that. So just a fun little fact, the first documented case of someone who died as a result of a car accident was in 1869. Mary Ward in Ireland fell off a steam carriage, as you see in this picture here. As it turned around the corner, she fell off and she got run over by the big steel wheel of the steam carriage. And she is the first person that we know of who actually died of a car accident. 50 million people minimally a year get injured in car accidents. And that's where we typically come in. If you see that, that's where we, sorry, I was just checking a few of the messages. When we see that the 50 million people are the people that hopefully will at some point come to our office to get much needed help. In the United States, the numbers went down for a short time and now the numbers go up. If you look at the category here, in 2015, 2016, the numbers went up. In 2017, they went down again, but the number of people injured is still higher than in 2015, as you can tell. If you look at police reported crashes, over 6 million a year. It's always a challenge, like how do you track accidents? Our police reports are not found to be very reliable. The injury rate per 100,000 is actually went up again since 2015, but down from 2017. So all this information is available on government resource databases, so it's all there. As I said, car accidents are completely preventable with the proper engineering tools, proper signage, dedicated lanes for bicycles, traffic lights when people cross the road as pedestrians, if you install traffic lights and other barriers, speed bumps, etc., etc. The World Health Organization is convinced, and I would agree with that, that in theory, all car crashes are preventable. It's a choice to drink and drive. It's a choice to speed and drive too fast in an urban area or in a highway. These are choices, and if we put the proper systems in place, they should be preventable. So what do we consider whiplash today? So whiplash is really, that refers to an injury to one or more parts of the neck, the cervical spine, or our colleagues Wayne in Australia would say cervical spine. In cervical spine, hi Wayne, how are you? That arises from inertial forces being applied to the head in the course of a motor vehicle accident that results in the perception of pain. Now, you can also apply this to other kinds of accidents, of course, when your head moves around very quickly. We'll go over that in a few minutes. But typically, it's reserved for motor vehicle accidents. So you're going to see here on this video a motor vehicle accident, pretty bad. So be prepared, pay attention, there we go. So this car had two crashes. It was hit by a big truck and then by the car with his dash cam. And surprisingly, the driver seems to be totally fine. Now, he's a very lucky man because many people would not survive this crash. He's not in a very crash-worthy car either, as you can tell here. What kind of crashes are most common? What you see here in the video, low speed, rear end collision. This is a study conducted by the Renault company in France. Looked at 8,000 crashes, 15,000 occupants, 27% were involved in rear end crashes, and that is really the most common scenario that we see. Side impacts, of course, frontal collisions as well. Side impacts are usually very bad. You have the least protection from a side impact, and if you wrap yourself around the pole with a car, chances are you won't survive that. But many of our patients were rear-ended, often non-expecting, sitting at a traffic light, at the stop sign, getting rear-ended by someone else, as you can see, with practically no damage to the car as in this crash. It's very expensive. The direct economic cost in the United States are $242 billion a year, and this is the last data that is available is from 2010. The comprehensive cost for days off from work, etc., is over $800 billion a year. If you see how much the government spends on the COVID pandemic, it kind of puts these numbers in perspective. Like, there's a lot of say that we will run out of money, that we can't support people. We are supporting people already through lots of other mechanisms that people get injured. Again, I mentioned alcohol and speeding before. $52 billion direct cost related to those, and indirect cost over $200 billion every single year. So it's important to recognize that with almost every crash, there are really three collisions. The first crash is between your vehicle and something else. That could be another car, that could be a tree, that could be a wall, that could be a pole somewhere, whatever it is. So that's typically considered the first crash. The second crash is between you and hopefully your seatbelt, if you wear one. If you don't wear a seatbelt, you're probably going to hit an instrument panel or the window, or you go right through the window. If you're in a frontal crash and you do not wear a seatbelt, chances are you will end up going through the window, especially in high-speed crashes. Children on the back seat who are not restrained have been shown to fly through the front window. Literally, they survive the crash, but they catapult out, go right out the window, and end up on the street. So a lot of people actually survive that second crash, the second collision, if they don't wear a seatbelt, but then they fly out on the street and either then they get hit by a car or the damage from just landing and going through the window is quite substantial. The third crash is probably the most interesting rest for its third collision, because that is the collision inside our bodies. It's your brain hitting the inside of your skull. It is your neck being so stretched back when your head goes back that your anterior longitudinal ligament may get stretched too much. Or your longus colli muscles may get hyperextended. Or you may have nuchal ligaments in the back that get strained. Or other soft tissues, fascia, muscle, etc., etc. So keep that in mind, these three different collisions. So we can recognize a few phases. Now we're going to talk about being rear-ended. So when you're sitting just in your car, as you see here in this crash test dummy, when you first get rear-ended, your trunk is pushed back into the seat and you actually move upwards. So if you think you kept your foot on the brake, you probably did not, because you were pushed away from the brake up into the air towards the head restraint, as you can see. So your cervical spine initially becomes compressed and it starts extending because of high tensile forces. And that's phase one. And you can see that here in this diagram. Your mouth typically falls open, not at very high speed. It doesn't need high speed. All the anterior structures, the sternocleidomastoid, anterior scalene, longus colli muscles, digastrics, all are at risk for being hyperextended, hyperstretched. What actually happens in the spine, initially you start at a normal curvature of the spine, but very quickly you go to an S-shaped curvature. You see that here, this S-shaped curve coming into the spine that typically is at C5, C6. And the lower cervical spine may go to really quite far in extension, maybe up to 84, 85% of extension, and combined with flexion of the upper cervical spine. That by itself can cause a lot of injuries already. You have dorsally directed shear forces that can actually hurt the facet joints or the articular pillar. You get a distraction of the anterior parts of the joints and a stress and compression of the more posterior parts of the joints. And that can actually lead to some level of injury already. There's quite a few studies. Dr. Yoganandan, who I've actually listened to in lectures, has done a lot of work on this. Brian Stemper is used to be with the Institute of Highway Insurance Institute of Highway Safety. So what they say actually, so you can actually get a lot of issues before or when your head hits the head restraint. It's not a head rest; it's a head restraint. Your anterior column tissues can actually be so stretched out that they're beyond the physiological limits, and you can happen injuries, minor injuries and severe injuries. In phase two, the trunk changes direction, now starts moving forward because the seat actually hits you back. The seat is pushed backwards, then the seat recoils, hits you in your upper spine, upper thoracic spine, your dorsal spine, forcing your head even farther in extension. If your head restraint is too low, chances are you will fly over the head restraint with your head, even more, causing potentially more damage to the anterior structures. So the head will be further back in extreme extension. The cervical thoracic junction, the lower cervical spine, and the craniomandibular complex are exposed to highly rotational and shear forces and are at increased risk for injury, just purely mechanically speaking, even at low speed crashes. You see that like this. I'll show you some videos later if you don't believe this. So if you look at the anterior structures, particularly longus colli, there's actually research, as you see here, from 2010. You see the muscle in the little animation that shows that there's a significant greater degree of muscle fatty infiltrates in these muscles in people with chronic whiplash-associated disorders when compared to healthy controls. You also see differences in the cross-sectional area of these anterior muscles. But the longus colli muscles are very important, and not many people, in my beliefs, to pay attention to them. But the longus colli muscles are related to greater degrees of instability, not just with your Ehlers-Danlos patient, hypermobile patient, but also with people after car accidents. They lead to greater degrees of kyphosis. So if you see x-rays like you see here, and the radiology report may say a lack of cervical lordosis, that almost always means that the longus colli muscles are shortened and actually maintain pull the spine out of that curved spike up to this into a straight spine with a greater degrees of kyphosis and therefore lack of lordosis. It's also related to vertigo. People with vertigo after whiplash, the longest colli muscles are very often involved in that. So the nice thing is that physical therapy, and shown here in this study from 2015, published in Muscle and Nerve, that exercise can actually help this dramatically. This was a study in women with chronic whiplash, and the fatty infiltration and the cross-sectional area actually improved with exercise. So that's where we come in, and we have to really train these muscles as much as we can. A long-term follow-up study, published in 2012, is a 10-year follow-up study, showed that it actually, if people are just left alone, there's really not much difference after 10 years between whiplash patients and healthy volunteers. They really didn't get worse per se than the healthy volunteers. I mean, if the status at the beginning, 10 years later, they had the same kind of differences, but they were definitely not increasing. In a second study of the same group that looked 20 years later after the whiplash crash, they did see that the people with the subjects of the whiplash, 95% had more degeneration of the cervical spine, but so did the healthy subjects. So there were no significant changes associated with the severity of related clinical symptoms. So in other words, you can see it on an MRI, but it had nothing to do with how bad these people were off. So there's indirectly a study that shows that the MRIs are really not the best way to figure out whether someone is symptomatic or not. So we do advocate needling the longus colli if necessary. A lot of people are a little worried about it, but it's just anatomy. I always tell people, do not be afraid of anatomy. You see in the cutout here, see there's the muscle, and if you needle that properly, right between the trachea and the carotid artery, the muscle is quite accessible to us. Dr. Christa Manette from Belgium has provided these pictures. These are actually images for a new book that we are putting together right now. You can definitely use ultrasound sonography as a reliable tool to measure the dimensions of the cross-sectional area, etc., of the longus colli muscle. You see it here with several other muscles around it. The longus colli is right here. This is at the level of C5, C6. Yeah, you can even see the vagal nerve coming in between here. It's a lovely, lovely picture. And what we also see that there are, between healthy subjects and people with whiplash, significant difference in the deformation rate in the sternocleidomastoid, longus capitis, and longus colli muscles. So because they're so hyperextended, the deformation of these muscles is actually more significant and measurably more significant. So these are all good reasons to consider the longus colli as a result of the first phase of the whiplash crashes. So if we look at the jaw, because that was the other area I mentioned before, there's no question. Here you see the jaw and the disc moving beautifully. There's no question in long-term studies, this is a prospective 15-year follow-up study, that the development of TMJ symptoms, both immediately and delayed, is very common in whiplash patients. The prevalence was much higher in the whiplash patients compared to the controls, 44 versus 20% in the beginning. Another study from 2007 from the American Dental Association. Here you see the disc going through the little clicking there. See that you go to the disc and the joint come down the disc. 1 in 3 victims of a car crash is at risk of developing delayed TMJ symptoms that may require physiotherapy and others. This study showed, by a bunch of dentists, clearly showed that the whiplash injuries often need a comprehensive management, often a multidisciplinary, where you may need dentists involved, a physiotherapist, osteopath, etc., with a multi or interdisciplinary approach. And of course, we always recommend the craft approach, and that you're going to hear about next week again with Harry van Piekharts, as he's going to talk about that. Looking at the seats, they are much better now than they were. If you look at the red seat in this picture, that's what car seats used to look like. In some of the antique cars, we can still see that these seats come up. Saab and Volvo were really the first two companies that spent serious time in developing safer seats. The Saab has a mechanism, a pressure sensor in this part of the seat, where you can see my arrows. So when you pushed up and back into the seat, it triggers this release and the head restraint actually comes forward. So instead of your head being able to go backwards, the head restraint comes forward and stop the heads before you start flying backwards. So that should really help with those interior structures not being damaged. The Volvo seat, called the whip seat, is very different. That actually allows the seat to go back. And I mentioned typically you get a recoil from the seat where it hits you from behind again. The Volvo seat, if everything works well, blocks that recoil because it locks the seat in place. So it cannot hit you again. So that second phase of the whiplash crash, of the injury mechanism, is kind of taken out of the picture. Here you see those in the video. This is the Saab seat. That's now been copied by many, many other companies. You see there comes the head restraint going forward and hits the head before it is too late. This is followed by the Volvo seat. You see that in the next part of this clip that I put together for you. So yeah, the whole seat comes up, just not your seat there, the seat goes up as well. This is not just the occupant goes up, the seat follows that same motion, and then the seat locks in place through this really ingenious, very simple mechanism, and therefore the seat cannot hit you again when you get rear-ended. The phase 3, so the head and trunk are now at peak acceleration forces, but the car is decelerating because you're coming to a stand. You're standing still, you got hit, so you got an increase in speed, your delta V increased. So now the head goes forward and you're actually going into flexion and rotation forces for the head and the trunk. So it's the head in relationship to the trunk. That's important. And in phase 4, the car no longer accelerates, the car stands still, but you're now at full deceleration. This is where the seatbelt really comes in handy, because if you do not wear a seatbelt, you're going to fly forward and hit your steering wheel or the window and go through it or not. But it's not going to be pretty. With the seatbelt will protect you from hitting the either the seat in front of you if you're in the back seat, or the instrument panels and the steering wheel, etc., etc. But the seatbelt will also cause more injuries, because now you have a pivot point strapped around your chest, you're moving forward, your trunk is being held back, and your head has full motion, full capabilities of continuing to fly forward. So that can cause pretty high and very unexpected, sudden high torque levels at the particular cervical thoracic junction, and that's where you often see that people got injured. You can also get injured in the anterior spine because of magnificent compression forces. So this actually increases the risk of cervical injury. Yeah, that forceful forward bending where the seatbelt holds the trunk back, but the head moves forward. It can be quite problematic. So you see that in this position. So now you're really all the way forward. Sometimes your jaw gets shut back really hard, which actually cannot put the craniomandibular area at risk as well. But you also are at increased risk of these posterior soft tissues in the third collision of the mechanisms that we talked about. And studies have shown, this is from 2016, have shown that people with whiplash injuries have higher deformation rates in the multifidi muscles compared to healthy controls. So even those deep muscles deep in the cervical spine, when you get forcefully moved forward, these muscles actually will have to stretch quite a lot. And particularly those muscles were definitely associated with whiplash-related pain. Also, the interplay between the deep muscles was much weaker, so altogether the neck muscles lost some of their stability and muscular support for the normal maintenance of a stable cervical spine. So following whiplash, you typically do see more instability in the neck. People don't feel like they feel like a little bit like a bubble head. Their head is not really connected anymore, and very often it leads to increased pain, persistent pain, and also disability. So a few years ago, in 2015, Michelle Sterling and a couple of other people, mostly in Australia, all in Australia, I think, did a study published in Spine on dry needling. Now, we're not going to talk a lot about dry needling in this webinar, but this is interesting because when I read the study proposal in the clinical registry, I was like, why would you do that way? So that 80 subjects, and from a research point of view, it's a great study. Michelle Sterling has done a lot of work on whiplash, and much of that work is really, really, really good. See, that's what she does. She studies whiplash, and if you ever get the chance to see her in a lecture, I highly recommend it. But this study did not thrill me at all. So people got 6 treatments with either real needling or sham needling, followed by exercise, and that was pretty much the same. For the sham needling, what they did, they needled muscles in the posterior neck. Yeah, the upper trapezius, levator scapulae, splenius scapularis, spinalis capitis. Frankly, I don't really know how you can differentiate some of these muscles based on palpation or maybe with ultrasound. And they did many tests that they applied to this study. So that looks really nice. 6 weeks, 12 weeks, 6 months, 12 months, long follow-up study. They found that dry needling and training was more effective after 6 to 12 months, but not after 6 and 12 weeks. And there was no clinical significant difference. So therefore, they said dry needling and training really has no advantage over sham dry needling and training. And that's interesting. That's an interesting finding, but it's clearly not my experience and also not the experience of others. So I think there's quite a lot of wrong with this study, and I'd say almost everything is wrong with the study. So the muscles most commonly involved in whiplash were not treated, such as the sternocleidomastoid, longus collar, anterior scalene. And the authors justify that by saying, like, if they needled in the front, they couldn't really blind the subjects, or they needled in the back, so the subjects couldn't really see what was being needled. The needling was very non-specific. They just put needles in the posterior neck in the various muscles. I thought that this study suffered from poor peer review, and also the study did not acknowledge that even sham dry needling, which in this case was superficial dry needling, still has physiological effects. So it's not really a sham needling procedure. You may be familiar with more recent studies that address the issue with, can you really blind properly for dry needling? It's a challenge. It really is a big challenge. So this is a study published in Pain, really prestigious journal. If you look at this study by Matteo Castaldo and colleagues, and out of Denmark, Matteo is actually Italian, they looked at, okay, where do people in whiplash get trigger points? Yeah, and the number of trigger points in the whiplash group was significantly greater than in the mechanical neck pain. And also the pain intensity was significantly correlated to the number of active trigger points and the spontaneous pain region. And not so much in the mechanical pain group, that only had pain duration. When they looked at which muscles are typically involved, you see here in the whiplash group, active and latent trigger points, you see the suboccipitals, upper trapezius, okay, sternocleido, levator scapulae, temporal, supraspinatus, deltoid, etc. But levator scapulae is right here, maybe. The splenius capitis, these weren't even mentioned. They didn't really find significant amount of trigger points. Yet those are the muscles that were needed in the previous study. So other things that can happen, you can get nerve root compression from whiplash crashes like this, basically because there's an exciting blood flow from the anterior internal venous plexus and cerebrospinal fluid through the intervertebral foramen. So this can lead to brain injuries, this can lead to nerve injuries, sudden lengthening of nerves, etc., etc. You can also get direct injuries to the facet joints. You get compression on the joints, you get shear forces on the joints. Sometimes if your head is in a rotated position when you get hit, you may even get rotational forces as well. Right there. Again, we already mentioned that some of the studies of the longus colli talked about fatty infiltrates. Yeah, this is a systematic review published in 2018 that said there's inconsistent evidence for cervical muscle fatty infiltrates and cross-sectional area on MRI. But it really is a mixed bag. So if you look at this paper, also published, and this was not included in the systematic review from the previous slide, they really looked at qualitative grading of muscle fat infiltration in whiplash patients using fat and water magnetic resonance imaging. And they compared healthy controls with people with mild, moderate whiplash-associated disorders and with severe. And what they found consistently that the people with severe whiplash had significantly more fatty infiltrates than the healthy controls, and also the people with the moderate whiplash-associated disorders. So clearly something may happen with muscular infiltrates, and strengthening, as I said before, is one of the ways you can treat that. Another study published in 2013 in the Scandinavian Journal of Pain showed that looking at high blood flow in the neck, they found many regions of increased blood flow and neovascularization. Actually, the picture behind here, every little star was an area of increased neovascularization at the insertion of different neck muscles all over. So the fact that that happened showed that there's actually an objective evidence that these neck muscles do get injured during whiplash mechanisms. Let's talk a little bit about seatbelt use. So yes, if you get in a crash and you get stopped by your seatbelt and you fly forward, you can get pretty serious contusions from the seatbelt, as you see in this collection of men from the UK. And they all have a stripe over their chest, and you can see if they're a driver or not, where the seatbelt basically hit the chest really, really hard, but it saved their lives. In the United States, the seatbelt use overall is 89%, which is much lower than in Europe. The lowest in the States is in New Hampshire, at only 67%, even 67.6% of people wearing seatbelts regularly. The highest, actually, surprisingly, was in Georgia. It surprised me, I must admit. In the United Kingdom, the UK, 31% of people who died in car accidents were not wearing a seatbelt. And that's only for front seat use. And not all jurisdictions in the world require seatbelt use on the back seat, which I would highly recommend. And hopefully after seeing this video, you will never drive a car anymore, and again, if people do not buckle up sitting in the back seat. I will not drive my car if someone's on the back seat without the seatbelt buckled on. In Romania, a study shows that 84% of people do not wear a seatbelt in the back seat. There's a study in the Journal of Trauma many years ago. I studied with Professor Mackay from the United Kingdom. He's a biomechanical expert in this field, and he showed a case where two couples went out to dinner. For a lovely evening out, they got in the frontal crash. The husbands were sitting on the front seat. They were buckled in, had airbags, everything. The wives were sitting on the back seat without seatbelts. And this is what happened. And as you can see, those forces are quite significant. And as you can imagine, in the case I just mentioned to you, the husbands were killed by their wives. When you hit the front seat that hard, if you wear a seatbelt, you still get hurt, but you're not killing the person in front of you. If you wear the seatbelt, you're fine. You may get hurt, but again, you do not crush the person in front of you, like in this example. In that car accident in the Journal of Trauma, both husbands were actually, in fact, killed by their wives, not by the car crash itself. So please wear your seatbelt. So what symptoms can we expect? Subacute, acute symptoms. I go through this very quickly because most of this you're familiar with. Neck pain, headaches, interscapular pain, extremity pain, and weakness. Back pain, paresthesias, cognitive difficulties. Dizziness, lightheadedness, facial pain, temporomandibular pain, clicking, closed lock positions, auditory symptoms such as phonophobia, tinnitus, loss of hearing, vertigo. Again, when you see vertigo, think that one of the things to think about is that longus colli. If you don't know much about tinnitus, come back in 2 weeks. So Michiel Trouw from the Netherlands will tell you all about it. And the other one is ocular dysfunction. blurred vision, photophobia. So we can test all that in the clinic. We can do lots of different tests that are covered actually in the crafted courses, and that Harry van Piekats and Michiel may be talking about the next 2 weeks. So it's a bit challenging because there are studies that show, this is from 2011, that video nystagmography did not really differentiate whiplash patients from normal controls, and they looked at smooth pursuit and saccadic eye movements. Other studies have different point of views of that they actually say, well, it did make a difference, and whiplash patients are not as good at that. There's quite a few studies on that as well. Other risk factors. Being female is a risk factor. You have higher risk than males, and that usually is because the size of the neck in women is usually smaller. Some people say women are smarter, so your brains are bigger, but that's of course not true. Well, the smarter part I wouldn't argue, but the brain part is not true. But women weighing less than 130 pounds, these American pounds, in frontal crashes tend to get injured more. A history of neck injury does not help, and the history of previous whiplash injuries does not help either. And a very common one is the head restraint being too low. If you're very tall, when head restraints are adjustable, make sure the head restraint, actually when you lean back, it should hit pretty much the higher part of your head. This is too low, and as you see, remember the impact mechanism, you will slide up and your head will fly over the head restraint. Other factors, it depends, how did you get hit? Were you hit from behind? Were you hit from the side? Were you hit from the front? These are some historic car crashes in Boston, I believe. Being hit from the side is always the worst. You have the least amount of protection when hit from the side. You have the most protection when hit from behind and from the front. Cars are well made for that purpose. Use of seat belts, critical. I can't emphasize it enough. If you don't wear a seatbelt, you take a significant risk of getting injured, as this dog seems to realize. Body mass index versus head neck index. The bigger your neck is, the thicker your neck, and the shorter your neck, the safer you're going to be. You have a decreased risk with increased mass and neck size. So that's one of the reasons females are usually at higher risk than males. That's not true for everyone, of course, but as a rule it is. Out of position occupant. If you're turning to the side, or you look in the mirror, or you see it coming, or you're talking to the person next to you, at the moment you get hit, your risk of injury is greater. If you look straight ahead, your risk of injury is significantly less. If your seatbelt breaks, or your chair breaks, the back of your seat, as you can see here, gets ended, crash, and the whole seat breaks. It's a good thing there's no child in that seat back and behind, but that could be pretty bad. That is a painful injury. And having your head turned at impact, here you see Stephen Colbert with the Prime Minister of New Zealand. If they would get rear-ended now, by their Secret Service maybe, that would not be good for Stephen Colbert. If you're not aware of impending impact, if you're totally minding your own business, all of a sudden you get hit, your risk of injuries, of acute pain is actually greater. On high-speed crashes, it really doesn't matter. If you get hit at a high speed or by a Mack truck, an 18-wheeler, you're probably better off not seeing it happening because you're probably not going to survive it, so it doesn't really matter. But at low speed, it does make a difference. Increased age makes a difference. If you're an older driver, you're at higher risk of getting injured. And the front seat versus rear seat. Now, it used to be the case that the back seat was significantly safer than the front seat, but today that also depends a little bit on the head restraints. The head restraints in the front seats tend to be much better than the head restraints in the back seat. I don't know of many cars that have the active restraint, forward moving head restraint like I showed in the video on the Saab. Mass makes a big difference. If you have a bigger car versus a smaller car from the same time period, the smaller car will always lose. So for parents amongst us here, if you want to get a car for your young child who's of your young adult who's now at the age of being able to drive, we all tend to get cute little cars. Well, cute little cars don't do very well in crashes. In this crash, you see a Honda Accord, mid-sized car, hitting a Honda Fit, which is a smaller car, and you can see the results. So there goes the Honda Fit on the right, Honda Accord on the left. And you see that the intrusion into the cabin, the molestation of the door and the frame on the Honda Fit is significantly worse. And that's really a matter of mass. This is in 2009, so it's a few years old, but the principle is exactly the same. It doesn't matter if 2009 or 2020. Crash speeds under 10 miles per hour actually have a greater risk of injury than crash speeds over 10 miles per hour. For those of you who don't count in miles, that's 16 kilometers per hour. So low speed crashes actually are a risk factor for acute pain and subacute pain. So for chronic pain, many of them are the same. So I'll go through this very fast. Female gender is again a significant risk factor. Rare impact versus others. Did you have symptoms within the first 12 hours, and how severe were the symptoms? You have ligamentous instability, so Ehlers-Danlos patients are at higher risk. You have initial back pain, if you have greater cognitive impairment, greater number of initial symptoms. Did you use a seatbelt or not? Yeah, neck pain with palpation. Did you have limited range of motion right away? Did you have muscle pain? Did you have neurological symptoms? Did you have a past history of neck pain or headaches? Do you have a headache now? Did you see immediate changes on the radiograph? Now, many people have changes on x-rays and all that, and they may want to attribute those to this crash, but that's highly unlikely. The crash really does not cause major difference in the spine itself. The loss of cervical lordosis, we talked about that. Increased age, front seat position is riskier than the rear back seat. And then also older cars are significantly worse than newer cars. So let's talk about high-speed crashes versus low-speed crashes, because that's an issue as well. There is a belief, in this case by Dr. Ferrari and Russell, there's a great name if you talk about car accident having a name like Ferrari. They wrote a terrible book, the Whiplash Encyclopedia, Facts and Myths of Whiplash. They actually published in journals that they do not believe that a minor motor vehicle accident can cause significant injury to the occupant. And that's a common belief system. But it all depends on your delta V, your change in velocity. If you have two equal cars, the beige one hits the yellow one will have a change in velocity because it will increase. The beige one has a negative change in velocity of delta V because the speed will increase. And they probably do okay. If you get hit by a truck with significantly higher mass, you're not going to be that lucky sitting in this red car, especially at high speed. So the fatality risk by delta V, the greater the speed change, the higher risk of dying, the higher risk of injury. In frontal impacts, in side impacts, the speeds have to be much lower and you already get injured. So here you see two crashes of two small cars. It's a Fiat versus a smart car. And you can see, especially in this picture here on the top right, that the Fiat is not doing very well. And the smart car is actually quite all right. Smarts are very small cars, but they're actually remarkably safe as far as their cage is concerned. If you get hit by a small car, by a big truck, by being in a smaller car, it's not going to end up very well. The people in this crash was a pregnant mother with a 4-year-old child, and none of them survived the crash. This was the first car, an 18-wheeler hit. Here's that 18-wheeler hitting the second car. So it went right through the first one, hit the second car. And this is the third car, and this is a car of one of my patients at that time. She was terribly injured. She was the driver. Her husband, who sat next to her, had no injuries at all. But not every high-speed crash has to be dangerous. This is on the highway, and you see people driving pretty fast. And up there, something bad happens. This was definitely a crash at very high speed, and no one got injured because the delta V of neither truck or this little car changed very much. They were pretty much the same. They were driving the same speed. It's scary, but no one got injured, as you can see here. If that car had rolled over, it would have been a different story. Here's another example like that from YouTube, where a car was pushed forward and the truck driver or lorry driver had no clue that there was a car on his bumper. The person was not injured, probably scared to death, but not injured. Bigger is also not always better. People always tell me like these big American cars that you used to have are so much better. Well, let me show you that that's not necessarily the case.
This show has been brought to you by Chevrolet on behalf of your local authorized Chevrolet dealer, who invites you to pleasure test the '59 Chevrolet, the car that's wanted for all it's worth. Chevrolet also brings you the backbone Chevy showroom each week on another network. And now this is Joel Alston speaking for Chevrolet in behalf of your local authorized Chevrolet dealer and reminding you to drive with care everywhere.
So that was actually a commercial in 1959, and here you see that same car being a crash test compared to a modern car. This is the Insurance Highway Institute of Safety, Highway Safety, 2009 Chevrolet versus 1959 Chevrolet. You see the 59 Chevrolet. There's nothing left of that car. It may be very big, but it had no structure, no crumble zones. And if you're in that car at this speed with an off frontal impact, you're not going to survive that. So yes, bigger is not always better in this case. Here you can see it one more time, and then we move on. That does not bode very well. So low speed crashes, people try to dismiss them. They're just a fender bender. The insurance company said, well, there's a lot of fraudulent behavior with that. People claim all kinds of things. Very difficult for accident reconstructionists because you need a dent to calculate speed. But studies have shown you can get injured at 4 kilometers per hour, 8 kilometers per hour. You can get whiplash-associated disorder of short duration. To show you what that means, I'll give you an example here. This is a 15 kilometer per hour crash. So it's not very fast. And again, at 8 kilometers, you already get injured. This is 15 kilometers, not a high, just a little bump, but you can definitely get injured at this speed. No question about it. So biomechanically speaking, this paper actually got an award. They said, no, the safety zone is really between 10 and 15 kilometers per hour. The studies have shown that not to be the case. And they said actually hyperextension of the cervical spine does not occur in rear end collisions up to 15 kilometers per hour if headrests are installed. Yeah, I would object to the word headrest, it's head restraint. Here's your crash. Look what happens. This is a crash at 10 kilometers per hour. The delta V is about 9 kilometers per hour, but the head acceleration was 13.5 G. Quite significant. That's a very high acceleration of the head. You see it again, and you can see how our head kind of stabilizes. You look at another crash, 15 kilometers per hour, 10 miles. You definitely see the head going significant hyperextension. Head acceleration was measured at 13 G. I see we're getting close to 6 o'clock here in the States, so I'm going to go over time a little bit. It's taking a little bit longer than I expected. If you compare the two, that both at low speed crashes, very high Gs. If you compare that to the head restraint, if the head restraint is good, it will really help. If a head restraint is poorly designed, if it's too low, it's not going to help you at all. You're going to get in trouble. So here you see another crash, also at low speed. You see the bump here. This person, see it in slow motion, definitely hyperextended. Look at the head acceleration forces, 12.7 G. Actually got injured. I would never volunteer for this kind of test. You see it in another one coming up. Boing. And now you see it really fast. Well, that's not a good scenario. And now with the crash test at high speed, 37, so 50 some kilometers per hour. This was a crash test dummy in the first car. And the head acceleration, surprisingly, if you look at here at the top of the screen, is significantly less than in the low speed crashes. So in a high speed crash, you may actually be better off than in the low speed crash. And this is a serious crash, a lot of damage to the car. And the crash test dummy in the first car, which you don't see in the video, had acceleration of 10.3 with a delta V of 17 miles per hour, so much higher. So if you compare the two, the low speed had higher acceleration than the high speed. And that's very counterintuitive, but very common. So the bottom line is property damage is not related to the risk for and the severity of the injury. Now, if you wrap your car around the pole, you're not going to survive. But there's a rule, property damage, and damage to a car has nothing to do with the risk of injury and the severity of injury. You can get low speed crashes, and it's partly because they're highly elastic, so they result in a greater energy transfer from the hit car that hit you to your body. In fact, the greater the damage to the car, the less biomechanical loading on you as the occupant. So we have to realize also that head accelerations are not the same as vehicle acceleration. So if we look at this chart, you see here, the green is the vehicle accelerations, but the head accelerations can be as much as 2.5 times higher than the acceleration of a car. So when people report the acceleration of a car, you really don't know how fast the head accelerates, and that's often done in court. So I think it's time that we also need to consider physiology and pain sciences and not just look at the biomechanics. In an older paper I published in 2005, I actually talked about whiplash patient featuring peripheral and central sensitization, the allodynia and hyperalgesia and myofascial trigger points. And the mechanism of injury in this study from 2013 also attributed a lot of the pain due to trigger points as the initiation and maintenance of central sensitization. They're one of the most important peripheral pain generators and initiators for central sensitization, according to Dr. Davis in this excellent article. So you get two different mechanisms, intercortical inhibition, intercortical facilitation, that could be altered by muscle pain. So you get decreased output, depression of cortical output, and therefore an increased level of pain. So you've seen already some of these papers. Central sensitization is a very common response in motor vehicle accidents, even when the mechanics suggest that you should not get injured. Here's another study from Freeman and Nystrom and Chris Centeno from Colorado that also shows that present data suggests that trigger point serves to perpetuate lowered pain threshold in uninjured muscles. So even if there's not a lot of damage to the muscle, you can still get pain. This study you already saw, people with whiplash have significantly more trigger points than people without, and therefore likely a greater degree of sensitization. The study comparing different people with pain in their neck showed that whiplash patients, in one muscle particularly, had significantly higher number of trigger points in the semispinal scapularis muscle compared to fibromyalgia, chronic pain, the both depression, and healthy controls. So people say, well, but what about the bumper? Should the bumper help you? Well, the bumper is not designed to protect the occupant of a car. Bumpers are designed to protect the car. And that's very unfortunate. So if you look at two Beetles, a European versus the United States one, the European Beetle, when you rear end it into a pole, dents, and the American one probably does not. So which car would you prefer? I guarantee you the European Beetle is much safer because it will absorb a lot of the energy from the transfer of the crash, while the American bumper doesn't bounces back. More American bumpers are movable, and the car will not absorb any energy. That energy is moved directly forward to the occupants of the car, probably being you, the driver of that vehicle. So bumpers do not protect occupants. They should crash. Talk about a little bit about legal aspects. Now we're getting to the end of this, and this applies mostly to the United States, but probably may be interest to others as well. One book that I found very helpful, and Amazon still has it for $3.99, which is cheap buy, is A Physician Guide to Expert Witnessing by our colleague Reda Abdel Fattah. Reda is a dentist in Boca Raton, Florida. He wrote this book, and I find it still today when I go to court, which I do sometimes on low-speed crashes as an expert witness, biomechanical trauma expert, sometimes as a physical therapy, but often as a biomechanical expert. I find this quite helpful. Most people who seek financial compensation in the United States do not have more symptoms. Yeah, many people are just looking at and what can we do? And in this study, only 7% had compensation for pain and suffering, but 34% of people had significant pain past 2 years. So there's not much evidence that people sue just to get money and that people present with more symptoms just because they want more money. There is no statistically significant relationship between litigation and the outcome in the United States. Litigation patients tend to report more symptoms. They're more aware that, oh, if I make my case sound horrible, I may get more. And there's, of course, all kinds of funny things about lawyers who do this kind of work, but most lawyers that we work with are actually quite honest. And it's nice to make fun of them, but they're usually quite honest. But what happens in court? Michael Freeman wrote a wonderful article. I will send this article to you in an email after this webinar with a link to this webinar as well, because this is being recorded. Don't fall for defense fallacies. And the most common things you see are very summarized here. One is the fallacy of distraction. that basically says, well, a crash either produces damage and causes injury, or it produced very little damage and no injury. So in this particular crash, there was no damage to the car, so no one can get injured. I've heard that argument many, many times. As you know now, there is no correlation between damage to the car and potential for injury. So this is a fallacy of distraction. The fallacy of authority. Some famous person, a well-known neurosurgeon, orthopedic surgeon, or someone like with a degree in biomechanical trauma, says that this could not have caused, the crash could not have caused a disc herniation, that because the forces were insufficient to cause the injury. There's no evidence of that whatsoever. So if you ever go to court, watch for these kind of arguments. You can change the argument quite nicely. The fallacy of induction. There's a study, or 5 people in the car, in the same car, no one got injured, so therefore this individual cannot get injured either. It's not true. The car showed you that was hit by the truck. The husband was totally fine. The driver of the car, my patient, was not. They sat right next to each other. Fallacy of generalization is very common. Most people are not injured when they're in car accidents of less than 6 miles per hour. Well, that's probably true. So therefore, it's highly unlikely that the plaintiff was injured in this subject, which had a 5 mile per change of velocity. That means absolutely nothing. That is just generalization that is not based on facts. Another fallacy is the fallacy of causation. The plaintiff saw treatment for neck pain in the month before the crash. So the person had already some neck pain. So therefore, the crash did not cause any more pain. How would you know? You don't know. Fallacy of irrelevant conclusion. The plaintiff claims a neck injury, but head restraints prevent hyperextension of the neck. So the car had a beautiful head restraint, so therefore the person cannot get injured. I've heard this in court. Fallacy of the part versus the whole. And the lawyer will argue that fractures and dislocation of the cervical spine rarely occur without disc herniation. Whether that's true or not is a whole other question, but they make say whatever they want. Going to court is not about justice, it's about who can play chess the best in the United States. So therefore they argue the plaintiff does not have a fracture and dislocation, so therefore the person cannot have a herniated disc. So insurance companies sometimes want to call in an accident reconstructionist, and they have all kinds of stuff. As you can see here, they measured the car speed and average acceleration, which we already know has nothing to do with your head acceleration. But that's what they say. Are the injuries consistent with those accelerations of the car? Well, they have no correlation at all. So this is a real report. So this speed that they calculate had virtually no risk to occupants. That's what studies have shown. So plopping in a chair, you see that here, as can be associated with 10 G, much less than what the speed that we calculated. But when you plop in your chair and your sofa at home, your head and trunk move at the same time. And there's no difference between the acceleration of the trunk versus the head. So it's a nonsensical argument. They said, they're not exactly comparable to average vehicle accelerations, but they make the comparison anyway. Very common. So therefore, they are inconsistent with the anatomical forces, so this person should not have gotten injured. Yeah, that goes on and on. Cited research shows that it's almost impossible to have a head injury with an average forward acceleration of 2.2 Gs. But that's of the car. It has nothing to do with that. These are very common arguments. When there is an accident reconstruction report, I love to go to court because they're always flawed. So remember that graph. So lastly, a commonly cited study in the court group by Mertz and Patrick, and then we'll stop and look at some questions. I know I'm a little bit over time, my apologies. Hope it's interesting enough that you want to stay anyway. So this study shows that 17 subjects were rear-ended in a crash test, and none of them complained about pain, and no one had a rotation of the head. So when you look at that study, no one had complaints of pain, no one had rotation of the head. I love this study because 15 of the 7 subjects were cadavers and they did not complain about pain. It's true. The 16th subject was a crash test dummy. The 17th subject was the author who had designed the study, did not complain about pain. The heads of the cadavers and the dummy were fixated against the board. With screws. So even if these board cadavers wanted to move their head, they couldn't. And the author and the crash test dummy were velcroed against the board as well. So physical therapy managed, first believe your patient. Patients do not have a worse prognosis because they had a whiplash crash. They just need a good evaluation and good treatment. Clearly 50%, this is also from Michelle Sterling, of an excellent paper. So clearly 50% will sustain a whiplash injury that will likely not recover. Yeah, but you can treat that. Many people have post-traumatic stress disorder, major depression, anxiety disorder is very, very common. So you need to consider those things. You may have to go back to the multidisciplinary approach. Is it chronic, severe, moderate, mild? Makes a big difference how well people score on standardized tests. Poor somatic and mental pre-injury health increase the risk of subsequent chronic whiplash. Another study. So symptoms, disabilities, and life satisfaction, 5 years. People complain more fatigue, poor memory, headaches, inability to sustain work. Fatigue at work is very, very common. So what I wanted to tell you in this, and now we stop this to really the last slide. It may be all very confusing, but I hope that you have a little bit better understanding that people in low-speed crashes can get injured, that seatbelt actually really help, and you should take it quite seriously. This is a picture of a park in Kuwait, where I've gone quite a few times, and it looks like a bunch of trash. And it may look like that in court. It may be all very confusing, like why this person hurt. There was no damage to the car. But in this park is one spot, when you look through that, you actually see that it's actually beautifully arranged. It's the same picture, just from a different angle. And you can see that it's all a nice, lovely statue with a lot of garbage. So I hope that helps you in your understanding of whiplash and why people complain about pain. So it's time for some questions. What about cervical thoracic syndrome? There's a question from Vladimir, I think from Latvia, if I'm not mistaken. Vladimir, welcome back. What about cervical thoracic syndrome? Now, one of the things I mentioned in the last phase of the whiplash is a lot of stress on the cervical thoracic region. So you mentioned Main syndrome, that is particularly, I believe, a T3, if I'm not mistaken. Yes, that could definitely happen. And again, if the forces of the forward head motion are so significant, you can get significant stretch at that level of the upper thoracic, lower cervical spine, and it's also possible even with the going backwards motion when the neck extends and that gets compressed and causes compression in that area as well. So that's very, very common. Question from Young, what is your understanding of occipital neuralgia associated with whiplash? Well, that's another great question. I did not talk much about neurological injuries, also not about brain injuries, which are also commonly occurring. You could definitely have occipital neuralgia, and that's also partly due to the stressors on the neck. I mentioned mostly the soft tissues. I did not mention any of the nerves, but these nerves, I mentioned one slide actually where the nerves also get stretched and compressed, but mostly it's usually a stretch injury, and it often results in occipital headaches. So yeah, a great question. You note that the longest collie, this question from Anne, scalenes are the most affected. Do you find the occipitals are injured at the same rate? The suboccipitals? No, that's actually not the case. They do get injured, and the study by Matteo from Italy did include the suboccipitals, but the suboccipitals are quite deep, and they're more in the level of the multifidi. They do get deformed a little bit. The suboccipitals are primarily involved when the head is caught in rotation at the time of impact. So when you turn to your side, you look over your shoulder, you look over there, what happens in the street, and now you get injured. Now there's a significant greater risk of actually injuring the suboccipital muscles. So yes, they are in the group to evaluate. Certainly with long-term instability issues following whiplash, that people really start contracting these muscles a lot more to create stability. I hope that answered that question, Anne. There's another question from Maud. Can cars often have headrests that are tilted forward that is hard to sit and drive with a forward head? Is that good to decrease likelihood of extension in whiplash? Yeah, that's a great question. Car seat design has gone through a lot of changes over the years, and the design of the head restraints as well. So yes, in some people, I have that too. I'm fairly tall, and in some cars, the shape of the seat and shape of the headrest actually pushes me forward, which is rather uncomfortable. So I'm inclined to put my seat farther back so that I could actually clear my shoulders and my neck. I would never buy that car. If I would, I mean, let's say rental cars, I rent a lot of cars through the year when I'm allowed to travel. In rental cars, you often don't have a choice, but I've changed rental cars too. It's like, I can't sit in this car. This is not safe. I'm pushed forward already. If I get in a crash, God knows what happens. Yes, it will prevent a little bit the forward of the hyperextension if you're pushed forward already. But at the same time, if you go past it, you will fly very fast over that head restraint. So I would avoid driving cars where your head is being pushed forward. And I definitely don't buy one. In a rental car, get another car. They usually have multiple models available, and it does increase your risk. Is there a possibility of injury to the thyroid? Yes, there is. That is a small risk. There are cases described. I'm a member of the Society of Automotive Engineers in the United States, actually an international society. They have published some papers in their internal literature volumes and conferences of thyroid injuries. I don't think it's very common. I don't think it's very well recognized either. So it probably may happen more than we realize, but it is certainly possible. Again, the thyroid being right in front, you get hyperextended. Everything in the front will get stretched more than normal when you go in that hyperextension. That could be a topic for a new webinar in the future. What are the consequences for the function of the lung? This is a question from Daniela. Hi, Daniela. How are you? You're up late. Danielle is from Crafter, teaches the Crafter Special Topics course, and has been in the United States teaching that a few times already. So, good question. What are the consequences for the function of the lung? I don't know the answer to that question, so you stumped me there. I'm not sure that there is a big difference, unless maybe your phrenic nerve got stretched, hyperstretched from C3 down. That's a possibility, but I don't know for sure that I can answer the question for sure that there really is a change in lung function. I'm going to look that up, Danielle. I'll get back to you on that one. Question from Jennifer. That's funny. This says, Jennifer said, this is not a question, but an interesting aside, which I'm happy to share with you. New Hampshire's motto is to live free or die. And maybe that motto carries over to the seatbelt use. I have no doubt that that's part of the attitude. If you don't like regulations, Alaska does that too. They're not very fond of regulations there. You're probably more inclined to say, well, I'm not going to wear my seatbelt. No one can tell me what to do. This is my car. I do whatever I want. Live free or die. It would be interesting to see if people in New Hampshire wear their face protection during COVID, and maybe they have the same attitude. I do not know that. Do you use any type of sub-classification to assess your patients? That's a great question. This is a question from Felipe. I do not. There are classification schemes available. The most common one used is the Quebec classification system. Michelle Sterling has modified that quite significantly, especially the class 2. I think if you do research, it's more important. For the clinic, I don't find these scales to be very helpful. Arthur Croft also came up with a classification scheme before the Quebec classifications. I think those are actually better, but they're not acceptable. People have not really paid much attention to them. So in the clinic, I don't believe that these sub-classification schemes really help you a lot in far as clinical management. There are others as well. There's a risk and injury of severity scale that I used to use, but it doesn't really guide the treatment all that much. It's more for academic purposes. I think it's interesting. If you do research, that may be useful, but in the clinic, I do not use them. Dr. Mohammed Asif from Pakistan again. Can whiplash cause pain in the legs? What do you think? Yes, the answer is yes. I can actually tell you that I got rear-ended once in 2009, I believe it was. I came home from the airport here in Washington, D.C., and was driving home, and there's one point you have to change highways. Traffic was terribly backed up, and I got rear-ended because I stopped and the car behind me did not. I saw it coming. I knew it was happening. I put in my emergency brake real quick. I put my hands on the steering wheel like this, and I put my head in flexion, and I pushed my chest and my head against the head restraint. And when after the crash, it was pretty hard. It was definitely not a low-speed crash. It was a high-speed crash. I did jump out of the car and said, like, oh my gosh, what happened? I hit the car in front of me in spite of my handbrake. That's how hard I got hit. And the first thing I felt were my knees. Because what happened is I had my hands on the steering wheel, and the steering wheel actually went down from the highest position to the lowest position. If I had osteoporosis, I would have broken my arms. So that's one possibility. I got hit by my steering wheel. More commonly, with rear end collision, not so common, but you do pop up out of the seat. You literally go up in the air, and you can hit instrument panels with your legs when you come back. You can sprain your ankle when you land again. There's definitely possibilities to injure your legs. But frontal crashes, this is much more common, especially in older cars when you have an intrusion into the cabin of the car, where the basically the floor pan where your feet are crushes into you. And in older cars, like you saw that 59 Chevy, in older cars, people would break their legs, people would break their knees, people would break all kinds of things. And I suspect in Pakistan, there are probably a fair amount of older cars on the road. So I think in Karachi, where you live, the chances are probably greater that people definitely get injured in their legs. In modern cars that meet American standards for car safety, that risk becomes significantly less. This is an interesting point. So maybe and comes back to the question about lung from Daniela. So she said maybe the scaling attachment to the pleura in the lung, pleural dome of the lung, could be stressed and injured in whiplash. It's possible. I don't know if that has been studied, but that's an interesting thought. Do you have ligaments for C1, C2 before to begin a treatment? We do ligament testing, and actually in our webinar on manual therapy, Keith and Porbo and Francis Young did review several of those tests. In the clinic, I don't do these tests unless I suspect that there's an instability. In our clinic, we tend to see patients fairly late. They usually go to other clinics, and when they don't get better, they come here. If there's any reason to expect cervical instability, we would do several tests for the instability of the neck. Now, none of these tests have very high reliability that I know of, but there are tests. And actually, I think Harry from PCATS has published a paper on one of those tests, if I remember correctly, but I don't have that in the top of my head. So. Do you find that, this is a question from Maud again, do you find that chin knots and lifts actually can improve longus colli strength after treating myofascial trigger points? What exercises do you recommend? Yeah, I think so. The key is to first lengthen the muscle. At least that's the approach we follow in our clinic. We first lengthen the muscle. Okay, we do a lot of dry needling, maybe some manual stretch, but you can't really reach that muscle manually. That's not that easy. It's quite deep. And then once we have done that, we actually do a lot of things about stability. You can lie on the ball backwards and lift up your head and do knots against gravity. You can do it sideline. You can combine it with slump testing. You can do people go through different patterns where they move their head in different ways. We can also deal with the cervical and oculomotor issues that a lot of these patients do develop, although some of the studies say that not so much, but there are other studies that say. So yes, you can combine a lot of things in your therapeutic approach to really try to strengthen the longus colli. And what you should also see, and I did have a patient who got that, but I lost the x-rays. So we had actually before and after x-rays of the cervical lordosis, and after the physical therapy, the lordosis was restored in the cervical spine, but I've never seen that published anywhere. So yes, I do think that does happen. Can whiplash be delayed? Another question from Dr. Asif. Yes, I did mention that, especially for the TMJ areas, what I highlighted. A lot of people don't have immediate symptoms. They may have some symptoms right away, but then maybe 2 days later, they're a little sore. When I got rear-ended at what I just mentioned, I forgot to mention that when I got rear-ended, I actually came home from a whiplash conference, so that was even more ironic. So I've been watching crashes all weekend, and when I came home, I got rear-ended myself. So yes, whiplash can be delayed. That actually can be delayed quite far, quite long. And I think if you watched last week on the lecture on fascia that Colleen presented, I think these issues, you have to really go back, what has happened to your neck? And then even when people don't see the link between the crash and the symptoms they may have 6 months later, even 2 years later, or 3 years later, you never can tell for sure. Scientifically, you can't really make that statement, but in the clinic, there's a lot of people with a history of whiplash who have persistent problems that they may or may not attribute to the whiplash. So the TMJ, I showed you the slide published in the Journal of the American Dental Association, that a third of patients, 1 in 3, developed immediate or delayed symptoms of temporomandibular disorder. So yes, the answer to that is most certainly true. Do you recommend, this is the question from Stu, do you recommend neck braces in the rehab process? I would certainly recommend neck braces in the acute stages, because if people are really very, very swollen and have instability and have no control of the neck muscles, I think neck braces are fine. But the neck brace is certainly another solution in the long run, unless you have severe cervical instability. But that's probably not that common. In an Ehlers-Danlos population, maybe a little bit more. But neck braces also have a risk of causing more muscle weakness rather than actually facilitation of strength. So I think there's a place for them in the acute stage, right after the whiplash. And actually, when you go to the hospital, if you can transfer by ambulance, they will almost always stabilize your neck to make sure till they know what they can do. So yes, there is a place for them for the time being. Thank you, Jamie, for your comment about this being a great webinar. I hope you liked it also. Do you have a webinar of manual treatment for chronic whiplash symptoms? Question by Amber. Wow, there's a lot of people I know on this webinar. Hello, Amber. We don't have a webinar for manual treatments, but it's really the same as what you already do in your clinic, Amber. Amber has written a wonderful book about myofascial pain, initially with her father, now by herself. So yeah, it's the things you already do. I think it's the assessment, what got injured, where do people have pain, what are the sources of peripheral nociceptive input, and you can use all the same manual techniques that you already use. You don't have to use needling at all. In fact, a lot of patients, we don't needle either. You don't need to. Needling helps because you can reach muscles and structures that without needles are very, very difficult to treat, but not impossible. I would think that anyone who skilled in manual soft tissue techniques can do all these treatments with soft tissue techniques. But I know I don't have a particular set of techniques for that, but I do that a lot. I use tools, I use my fingers a lot, my hands a lot. Now, if it's in the neck, it's all very delicate. You have to be a little careful, but that's certainly all possible. I think we came to the last question. Wow, and it's a little bit over time. It's 6:30 now here, and in Pakistan it's 2:30 or 3:30 in the morning, I guess, by now. So time for you guys to go to bed. This was the end of this lecture. You will get a recording of this. It will be ready probably by tomorrow night. You should have it no later than Thursday in your mailbox. You get an email from me with a link to this whole webinar. I will also give you an article by Freeman on these fallacies in court, because it's just a fun read. And with that, I wish you all a wonderful evening and a wonderful morning if you're in Australia, and wherever you are in between. In India, there's people from India signed up as well. Thank you very much, everyone. This is the end of this webinar, and we'll see you again in the near future.